So from week 1, we came up that we wanted a single point of access which was 24/7, and all of the various people listed here, GPs, ambulance, third sector, other trusts, 999, service users and carers, all other members of the public can refer into this single point of access. It's going to be a single number, it's going to have web chat and all of the bells and whistles that we have in this day and age. The single point of access is going to be able to offer advice and information, so things like signposting people, giving out telephone numbers for various services that are around, changing appointments, making appointments for patients, feedback, that's like dealing with compliments and complaints, and also be able to provide clinical advice and information, so that would be from medics, nurses, non-medical prescribers, pharmacy, etc. And they will also provide risk information, so sharing information with the likes of the police, 111, 999. They will also be able to refer non-urgent referrals, but I've left that one blank because that is workshop 3. But this week we're working on the urgent referrals, so this is this part here. So it might be that at the single point of access they decide that it's more than urgent, it's an emergency. In that case, they'll be ringing 999 and that person might have to go to accident and emergency. It was agreed yesterday, I believe, from the flip charts that I read, that you would only go to accident and emergency if that person required medical treatment. Is that right with everybody? Yeah. Excellent. And at A&E, they would be seen by the psychiatric liaison team. Marvellous. If that person didn't require medical treatment, they would go to an alternative to A&E. So some of these are listed here. So we had day hospitals, shared care team, carer support, outpatient clinics, a 24-hour telephone helpline, which is this one, walk-in centres, respite beds, night cafes, crisis lounge, GP and mental health bus was on the list, and hospital at home. Okay, does that sound right to anybody? Have I missed anything off? Excellent. If it's an urgent referral, it goes into 2 categories. Obviously, well, it'll be known patients and unknown patients, but both of them, that person who's on that phone who's doing the triage, that clinician, would talk to that person, try and find out what's going on. There is some standard work that was on another piece of a flip chart about kind of trying to de-escalate the situation. If the patient is known to the service, everybody should have access to their care plan, their crisis contingency plan, whatever you want to call it, their RAP plan if you like, stepped plan I think we had in the first workshop from a service user. So they'll be able to access that plan and talk to the patient around what works best for them. In either case, they're going to have to determine the best course of action. Okay, so at this point, it might be that they decide that it's a non-urgent referral after triage, and that will just be passed to the non-urgent referrals, which will work up in workshop 3. It might be that IACT is the best way for them, so they'll be signposted to IACT or referred directly. It might be that they need some peer support. Might be that they need to see their own practitioner if they're a known patient. Might be that they need to go to the crisis lounge, speak to their GP or a medic. Might be that they've got their own skills according to their plan, and it might just be that they need that telephone support in order to kind of remind them about those skills and how to utilise and implement them. It might be that they're okay to go back with their friends, family or carer. Might be that they need a referral to social care, might be they need a referral to the third sector, or it might be that they either need a review by the team for maybe known patients, or that they need a full crisis assessment, even if it's for known patients, something might have changed that they're needing that full crisis assessment. So, following their assessment, they need to decide on the best course of action, so it might be that they might need the police, might need 999, depending on the circumstances. The shared care team. It might be that they need home treatment from the crisis team. It might mean that they need hospital admission, and we've got these little green dots here just to say that there are some standard work that was done yesterday around these particular areas. Might be that they need an AMP for a mental health act assessment, and again there's a green dot there because there was a lot of work done yesterday around that, or it might be that they need an alternative to hospital. Have I missed anything? Obviously it's not finished, we're only on Wednesday morning, so all of these things where it hasn't quite got a green dot, that's what we need to work on for the next 3 days in order to get that, you know, what Stuart was talking about, that granular information, that step-by-step instruction of who's going to be doing what, how they're going to do it and what it's going to look like. Does that make sense? Excellent.
Stunned silence.